Hi, this is Julie Lubinsky. I am web manager for the Christopher and Dana Reeve Foundation, and I'd like to welcome you all to this month's chat with Nurse Linda. I want to tell you a little bit about her. She is a leader, a teacher, and a provider of rehabilitation nursing for over 30 years. In fact, Nurse Linda worked closely with Christopher Reeve on his recovery and has been advocating for the Reeve Foundation ever since. And we are so excited to have her here on a monthly basis, live to chat, and she's also available on our online community at christopherreeve.org/community. You can look for Ask a Nurse there, or christopherreeve.org/nurse, which I believe is on the slide. This is being recorded, so you will be able to view this by the end of the week at christopherreeve.org/webcast. And now I would like to turn it over to Linda to tell us a little bit about our topic today.
Well, good afternoon, everyone, and it's nice that you're able to join us today, or if you're listening later, welcome. This month, I've been writing about bowel programs, so I thought I would open off the webinar today in talking about bowel programs. You know, for people who do their bowel program and it just works like it's supposed to work, that's just marvelous, and you know, you should consider yourself very lucky in that particular department. However, a lot of the listeners I know will be shocked to hear that some people's bowel programs work so predictably and so well. And of course, the people that I deal with more in bowel programs are people who are having problems with their bowel programs. And generally the big complaint is it takes so long. And I know some people have had some real horror stories, and trying to help them get through those processes to get their bowel programs in line can be quite a challenge, and it's very individual. So there's not like, oh, well, if it's taking too long, then do this thing. You really have to work a lot with bowel programs. You know, bowel programs are a funny thing because people are very sensitive about that part of their body. It is always amazing to me that people will stick their finger in their mouth, they'll stick their finger in their ear, they'll stick their finger up their nose. But if you talk about doing digital stimulation in their bowels, then they're like, no, we're not doing that. So it's just one of those things that you really just have to learn to deal with in your mind. Inserting the suppository, doing the digital stimulation, these are the things that are going to make your bowel program work and work well. And so I know that it's a really tough battle to get over. I know when I was in nursing school, and I was first presented with, you want me to put my finger where? And some stranger that I've never met before. Okay, that's an interesting proposition. So for me, I thought, that would be kind of hard to do. So in my mind, I thought, okay, Linda, as long as you have a glove on your finger, it's okay. So I just, people have to learn to come to grips with these things in their own mind. It is not something that anybody's thinking about, oh, good, I get to go do this. This is like the great moment of my life. It's more like, oh, I have to go do this. But it is something that we really, keeping the bowels in order can be a challenge. And so it is something that we want to keep on top of, make sure that things are working in a good manner. And so the first thing in one of the blogs I had discussed, the first thing is really reviewing what you're doing in your bowel program. So a lot of people, will just stick the suppository in and okay, there it's in there. But the suppository has to be placed up against the wall of the bowel to work. So if you put the suppository in stool that should be there, and you put it in the middle of that stool, it's not going to melt as well. And if it's in there, the suppository is going to stay within that cluster of material, and so it's not going to really stimulate the bowel to work. The way suppositories work is that they have to be placed up against the wall of the bowel, which then the suppository will irritate the wall of the bowel, and that's what stimulates the bowel to evacuate and function. So, so that is one of the first things. And then the second thing is to do the digital stim. We all see the external sphincter. That's where we know where we're headed in the bowel program. But what most people don't realize is that there's an internal sphincter, and you really have to be able to stimulate that and cause that to open to get the bowel to evacuate. So a lot of times people just aren't understanding what they need to do to get their bowel program to work, and then really spending the time to do that. And so I can see there's a question already. It's what kind of doctor can you consult with concerning bowel issues and complications? So that is a great question, because if you are having trouble, you really want somebody who's knowledgeable with what's going on, and probably the type of doctor that knows the most about the bowel program is the physiatrist who deals with people with spinal cord injury, because they're hearing what people are telling them, and they understand the mechanism of how the bowel works after the spinal cord injury. So people who have neurogenic bowel, it has a special kind of following that goes with people who study that sort of thing. So that would be my first line of defense. You can certainly talk to your primary care physician, who might have some strategies, but they might not know that much about neurogenic bowel. In the general community of just people at large, if somebody has difficulty with bowel movements or intermittent problems with that, generally laxatives will be prescribed, and that is like the worst thing that a person with spinal cord injury can do to themselves, because first of all, what will happen is the laxative works going completely through the gut, so through the stomach, and it starts at the very top of the bowel. And the bowel is a very, very, very long organ that's all smushed together in your abdomen. So when you take a laxative, what happens is that will stimulate your whole entire bowel to just swoosh and evacuate out. So it's very unpredictable. But even more important, when you're taking laxatives inside the bowel, all along the track of the bowel, there are these tiny little fibers that are constantly moving the stool along, and that's the way the bowel works. So once there's some fecal material in there, these little fibers are like little miniature hairs, like the little miniature hairs that you have inside your ear that help you hear. Well, these are little miniature hair. They're called cilia, C-I-L-L-A, and they're inside that bowel, and they're like little hair fingers almost that are constantly moving that stool one direction, which is out. And so when you take a laxative, what happens is that washes out the whole bowel. It moves through the bowel very quickly, and it washes away those hairs. And if you take enough laxative, those little hair fibers get eliminated. So then you have to take more extreme measures to have a bowel program. So that is the one thing you really want to keep away from. Now, people like taking laxatives because then they think, oh, I don't have to use a suppository and I don't have to do the digital stimulation, but those are the most natural way that your bowel works. So you always want to start with the lowest intervention, and then if you have to work your way up the next step of the ladder of interventions, you still have possibilities. So taking laxatives is going to take away your possibilities. Another doctor you might see is the GI specialist, the gastrologist. There are people who specialize in the gut, and they'll have a little bit more information about spinal cord injury, especially if you have complications, such as if you have ulcers or if you get hemorrhoids, or if you have some bleeding from your bowel. They're the people who do the colonoscopies. That you can see gastroenterologists, GI surgeons if you need to have, if you have a blockage or if you need to have surgery for some particular reason. So really starting with your spinal cord injury specialist doctor, your physiatrist, is going to be your best bet. If you're just having problems with your bowel program and you are familiar with a rehabilitation nurse. They are the ones who are doing the bowel programs day in and day out with people on hospital units. So if you're having problems with just the program itself, you might want to try to find a rehabilitation nurse who can kind of walk through the steps and help you see what kind of issues you might be having to correct your bowel program. When you get into issues with the bowel, then you need to see with the bowel function itself or with any kind of complications, then you really need to see a specialist, somebody who can direct you. Maybe if you see your physiatrist, they can say, well, I usually send my patients to Dr. So-and-so, and so I know that doctor has a good working knowledge of the neurogenic bowel. Of course, we really, really try to avoid surgery. If there's a severe complication, even if there's a complication for hemorrhoids, where I live now, there is a new hemorrhoid clinic, and they have this beautiful commercial with this lovely music that plays. You really get intrigued about, oh, what is this thing that you're trying to sell me? Oh, it's hemorrhoid surgery. And it's such a problem in society because of people's lack of exercise and diet, not necessarily just for the community of individuals with paralysis, but in the community at large, their hemorrhoids is a huge problem because people, try to contain their bowel movements. They don't want to go, like while they're at work or out on a date or something like that. So in general, or women who have just had children will have problems with hemorrhoids. So this commercial is very enticing to come in and have hemorrhoid surgery. But if you have any form of paralysis, you want to try to keep things as natural as possible and avoid any kind of complications, because you want to avoid surgery at all costs, which is on the extreme level of treating complications. So even if you have some hemorrhoids, if you note that there are hemorrhoids there, right away start with some hemorrhoid shrinking medication. Tuck the hemorrhoids back into the bowel to keep them moist so they're not constricted, and try to avoid surgery, because after spinal cord injury, breathing is so very difficult. With having surgery, people are usually put in different positions. Sometimes they're put on their stomach with their knees underneath them. Sometimes their legs are put up in stirrups, but it causes a lot of problems with breathing when you have surgery of any kind. So we try to avoid any kind of surgery because the complications and, laying on the table and not moving, if skin complications, the anesthesia sometimes doesn't wear off well with people with breathing problems. So there's lots and lots of complications that can come from that. So long answer to a very simple question from Jennifer there, but a very long answer is, so talk to your physiatrist, or if you're having problems with your bowel program itself, talk to your nurse. One thing I did want to mention is dietary adjustments to your bowel program and increasing fiber. And I know I've said it in the blog, and people say it all the time. And I was thinking about that. We tell people, increase your fiber, increase your fiber. Well, how do you go about doing that? Well, if you just eat one more serving of a fruit or vegetable, you're really going to dramatically increase your fiber. There are fiber medications that you can take that will increase your fiber if you find that you can't correct it with a dietary change, but just adding one serving of vegetables or one serving of a fruit per day, and you're going to see a big difference in the consistency and the time it takes for you to do your bowel program. So food for thought there, and food for your bowel there, I guess, too. Okay, so the next question is, how long should you do DigStim? Well, that is a very good question also, because it's going to be a little bit different for everyone. But generally what you want to do is you want to do the DigStim long enough until you have relaxed that internal sphincter in your bowel. So how long is that going to be? Well, it might be up to a full minute. Some people might take a little bit longer. Some people might do a little less. But be sure you have a well lubricated finger when you are doing your dig stim, and see if you can feel that internal sphincter. It's not up very high in the rectum. It's only up a couple of inches, so your finger should be able to do it. Now, some people will not feel that internal sphincter. So if you can do it even 30 seconds, that would probably be good enough. But it's usually about a minute to really get that internal sphincter really relaxed, and that is what it not only it opens up the bowel so that the evacuation can occur, but it also is stimulating that lower end of the colon, which is starting that peristalsis, or that movement to get the stool out. You can also try some things that will help increase your peristalsis if you do your bowel program about 15 to 20 minutes after you eat a meal. Eating food will stimulate the gut to move. It's moving all the time, but eating food creates a stronger stimulation. Some people will just drink a cup of hot fluid, and that really stimulates the bowel to move, so that is also very helpful. So the next question is, should you have a bowel movement every day? Well, that is a great question, because, there are times in our society where people were like, oh my gosh, you have to have a bowel movement every single day, which is not necessarily true. Generally speaking, we recommend every other day in the healthcare field, every other day being enough. Now, some people in their normal lives without spinal cord injury have a bowel movement every day, and what has happened is that they have just trained themselves without knowing it. People train themselves and they'll have a bowel movement. Maybe they have a cup of coffee after breakfast. That's a great recipe for having a bowel movement. First of all, it's early in the morning, so while you sleep, the peristalsis, or the movement of your bowels, slow down. They're still moving, but at a slower rate while you're asleep. When you get up and you have breakfast and you start taking in food, especially if you take some kind of hot or warm fluid stimulant, that really is like a shock to your bowel, and it's like, wake up, get moving, get going. And so if you've been in the workplace and you've ever gone into the bathroom in mid-morning, it's like, whoa, this place stinks to high heaven. It's because people have gotten up, they've had their breakfast, they're moving around, they've had their coffee, and they have trained themselves to have that mid-morning bowel movement. Now, this is probably not what people think about, but being in this world is like, oh, okay, I see what's going on here in my place of work. So people have trained themselves to have a bowel movement every day just by the nature of their behavior. Now, they haven't set out to do this, they haven't thought about it, but this is what's happened to them. Other people maybe have a piece of fruit every day, and that's enough to stimulate a bowel movement. Or maybe after their exercise program, all that movement stimulates a bowel movement. So people have trained themselves in certain ways without purposely going out to do that sort of thing. After paralysis, and it could be after a stroke, you could have problems with your bowels if you have MS or Parkinson's disease, or really any kind of disease that leads you to be less mobile. Or spinal cord injury is the one, of course, that we think about. So we recommend that you only perform the bowel program every other day, and then it's this action that you are taking to get the bowel to move in a timely fashion when you want it to happen. But the key is to be very consistent. So it's exactly when you want it to happen at that particular time every day. When you go to the rehabilitation facility, usually patients are asked, when do you have a bowel movement? And most patients will be like, well, I don't know, just whenever I have to go. And that's the way most people are. Most people aren't sitting there thinking, oh, it's 10:05, I better go move my bowels. There's a character on TV on The Big Bang, Sheldon Cooper. He moves his bowels at 8 a.m. every morning. And that's just what his, it's kind of the joke of his character. But there are some people that are that in tune to their bowels. But most people are like, oh gosh, I don't know. It's just whenever I have to go. If I eat something spicy, I have to go. Some people have cheese and they get diarrhea. Some people eat cheese and they become constipated. So it's kind of different for everybody. It's very trial and error. So should you have a bowel movement every day? You probably don't need to every day. Every other day is probably enough. There are very few people that will do it every third day, and they're able to accommodate that without any accidents. But there are people who eat very, very small amounts, and waiting that long is going to increase your chances of some sort of impaction. But if you're doing that, if it's working for you, well, then you should probably continue with that if that's working out in your life. But every other day is the recommended amount. If you're having accidents in between, you can do your bowel movement every day until you get your bowel regulated to move at that certain time of day. Consistency is going to be the key for the bowel program. So when you go to the hospital, you get assigned you're a morning bowel patient or you're an evening bowel patient. And so your bowel starts getting trained in that way. It does not get trained overnight. It can take weeks to months to get your bowel to be a predictable time for it to empty. If you decide you want to change your bowel routine, you have some event coming up and you want to do it earlier one particular day, that's fine. It's not going to mess anything up. But you want to be very strict with yourself about this is going to be the bowel time every other day. If you're a morning bowel person and all of a sudden something happens in your life, you get a job or something happens in the timing of your life and you need to change to an evening bowel program, you can certainly do that. You would want to start just in the next the next cycle for your bowel program to start at the new time, but to be very consistent that is going to be your time. So here's another question about a person who has an incomplete fraction, and his problem was constipation until 3 years ago. Now the problem is having a bowel movement every 4 days, but loose stools unless he takes medication to stop it. Okay, so probably what's happening for this person is they used to have a tendency towards constipation, and then about 3 years ago something happened in their bowels and their stools changed, and so now they have loose stools, and he's taking medications to slow down the stool. So when the bowel movement changes to loose stools, the first thing that we want to do is check for some kind of impaction. So if you've been constipated and the stool's been hard, it's been slow to pass through, and now all of a sudden you're having loose stools, the first thing we always check for is some kind of impaction, and it may be higher up in the bowel, that maybe there's a blockage of some sort, some hard stool got stuck there in one of the turns or loops of the bowel, and so what's happening is that liquid stool comes around that. So that's the first thing we look for. But once you've ruled that out, our bowels are always changing, and so it's as we age, everything in our body becomes different. We'll be very consistent with something going on, and then all of a sudden, boom, it's just changed. And it seems like it's overnight, but it's probably taken a while for that to happen. So if you know that there is no impaction and you're taking medication to stop the loose stools, when the stool is loose, what we know is that it needs to be bulked up. So it could be something in your diet. Maybe you're on the same diet, but maybe now your body says, I don't need so much fiber, and so that's why it's becoming loose, or probably more likely is your body is saying, I need to have a little more bulk in here. So if you add some psyllium, some fiber to your diet, then you'll probably firm up your stools, and you won't have this problem with the loose stools, and hopefully you'll be able to get off that medication. So there's one thing with adding some bulk. Now there's another thing with having an infection in your bowel that you may or may not be aware of. So first of all, let's talk about adding the bulk. And we usually add bulk with our stools through the use of fiber, either through food, or you can buy some over-the-counter psyllium, which you can get just from the grocery store or the health food store. You would want to add bulk without adding sugar. So there are several different brands, and some of them I'm going to mention by name. I'm not recommending one over another because it's personal preference. They all work equally as well. But Metamucil being the one that's most well known, and I'm mentioning these brand names because I think this is you're going to be like, oh, I know what she's talking about when she says psyllium. That is the fiber. It's a natural fiber that is put into these products. So Metamucil is one. It's an orange flavor. It also has a gritty consistency to it. You have to mix the powder in with some water, and then you take that. So you swallow that down, and it works throughout the bowel. It's technically called a laxative, but it's adding bulk, so it's not flushing out the bowel. It's just helping the stool move through. So it's a little bit different formulation than your traditional laxative. Another is the Citrasil, which is, you'll see that advertised on TV. It's also psyllium, but it has no flavoring to it. And it, you put it in a glass of water. The water doesn't change color. You don't notice it. You just drink the water and it tastes pretty much like water. If you let it sit too long, you'll see that it starts to kind of get like very loose jello. Either one of these products will look kind of like a thickened jello, you know, in the cup. So you want to take it down right away so that it thickens in your bowel and not in your glass. So those are some things. You can also buy these little cookies that you can take, but you still have to take a large amount of water with them because, again, it's a psyllium and it needs the water to become this jelly to go through your bowel. So you need to take water with that. And then the other thing is watch the product to see how much sugar is in there because there can be a lot of sugar for taste in the psyllium. Sugar comes naturally in the psyllium, but the people who manufacture these products will put a lot of sugar in there. So look for the sugar-free and then look and see what kind of sweetener has been added in there. So if you're allergic to aspartame or some of these other sweeteners, you know, of course you don't want to do that. You can buy plain psyllium at the health food store that's just psyllium without anything added in. It just looks like a little brown like sandy kind of thing. So you can do that. Now, the other thing about that I mentioned is you could have an infection in your bowel, and that can lead to loose stools. There is an infection that gets in people's bowels called C. diff, and you may have heard of that. It has a certain smell to it. So when you do your bowel program, if once you smell C. diff, you always know. We always kind of have a thing in the hospital when we talk about, well, we have to send the stool sample off and we'll see if it has C. diff. And as a nurse, you know that when you're dealing with C. diff, you know the smell of it. You don't need to send it off. You know if it's there, if it's not. So it's a very strong odor. Now that's a bacteria that can get in your bowel that just it lives in there. There's treatments for it. It's kind of hard to clear up. But since you've had this for 3 years, I doubt that you have that. You might have a very, very light case of it. Another thing you might want to try is in the bowel, there are bacteria that help digest your food. They're bacteria that live in our bowel, but we want them to live in our bowel because they're helping us. And they're helping us digest our food, and this is just the way the body works. So these bacteria can be found in yogurt cultures, or you can take some of the different probiotics. Those are the bacteria that live in the bowel. So you can take some tablets of that and try and see. Always check with your healthcare professional before you do something, but if you want to get your stools to be less loose, eating some yogurt. And again, it won't be like I ate yogurt today. I expect my bowels to be cleared up tomorrow. It will take a couple of weeks or more to see if that is working well. If you don't like the taste of yogurt, you can check into the probiotics and check with your healthcare professional to make sure that that's okay. But I suspect that that will help you clean up, tighten up these bowels. Now you've been taking medication, and there are medications for antidiarrheals. Flagyl is one, that's a prescription one, but there's other anti-diarrhea medications, so I assume you're taking those. And so because you've been on those, it might take a little bit longer for the yogurt or the probiotics to work. So you don't want to stop taking your medication. You want to slowly get off of that if that's going to be possible. So you'll want to just double check. You'll want to check about that with your healthcare professional before you switch your medications around. So does drinking warm liquids help aiding bowel movements? Oh yes, that is ever so true. You want to take the warm liquid either after a meal, or if you find that 3 o'clock in the afternoon is your perfect time to do your bowel program, and that's when you want to do that, that's perfectly fine too. Just have a couple of crackers, drink a glass of milk, have a coffee cup size of some warm liquid, just even water, coffee, tea, any of that, because that warmth hits your bowel and it stimulates those little fibers to move. So it stimulates the peristalsis in your bowel. And yes, drinking warm liquids will help aid a bowel movement, but you should drink them just at the time before you plan to do your bowel movement. So if you drink some warm liquid at 10 o'clock in the morning, it is probably not going to aid your bowel program at 8 o'clock at night. It's going to help peristalsis, it's going to help move things along, but you're really going to get the benefit if you drink the warm liquids right before the time of the bowel program. Okay, so this person has a bowel movement every day, but my stomach gets very bloated. Well, whenever we eat food, it goes in our stomach and then it enters down into our bowel. So it goes straight there. And when we put food in our bowel starts working to digest it. So people get that bloated feeling, and they feel like their bowels expand, and that's because that's exactly what they're doing. And so every time you eat, you might have that bloated feeling. Now, after a spinal cord injury or with some kind of paralysis where you're not moving your legs much, that bloating will feel worse to you or will look worse to you, because when we get up and move around, activity is very important to aiding our bowel movements. Now, I haven't said much about activity in bowel movements, because for people with paralysis, that's a hard thing to achieve. So if you see some people after they eat, they enjoy going for a walk, and that helps get that movement, that activity going, to reduce that bloating that occurs because now food is in the bowel, and it's just a natural process. Is that the intestines are going to enlarge themselves because they're busy working. So if you have paralysis, if you want to do your stretching exercises or pull your legs up to your stomach, or if you're sitting in your wheelchair and you do your pressure releases and you lean your body and drape your arm over one side of the chair and then lean and drape over the other side, or bend forward, being careful not to bend out of the chair. You don't want to topple over. But if you can move your abdomen in any way, pulling your legs up to the abdomen, even just a little bit, you'll notice that bloating feeling goes away, or at least that look of the bloating. But that bloat is there because your bowel's doing what it's supposed to do. When we get up and move around, that air or gas moves on and moves a little bit faster and then gets expelled. And so that's why people don't notice it so much, but if you just sit after a big meal, you'll notice you get very bloated, and that's why, because things are not moving as quickly as they could be. So doing any kind of activity, even if it's passive, moving your leg up to your abdomen, or having somebody help even roll you from side to side, that will help reduce some of that bloating feeling. Spinal cord injury and the flu. What are some common complications? And that's okay. We can talk off of the bowels for a moment. That would be kind of maybe a restful break for some people. But anyway, so the flu and spinal cord injury. Well, one of the biggest problems for people with spinal cord injury and getting any kind of flu or virus or any kind of disease that's going to affect the stomach or even the lungs is going to be, first of all, it's going to be, let's talk about the lungs first, because breathing is the thing that keeps us going. So that's a very important activity. And if we have the flu or a heavy cold, we have some kind of infection in our lungs, it makes our breathing a little more laborious. And so that can be very difficult. So that's probably the biggest thing if someone gets the flu, is thinking about what's going to happen to the breathing, because even if you have a lower level spinal cord injury, certainly if you have a higher level injury, you know that you have effects on your respiratory status. Even if you have a lower level injury, you might not realize it, but when we breathe, you know that there are muscles that, well, our nervous system causes us to inhale and exhale, and we do this without thinking. It's part of the autonomic nervous system. We can also control it, which is kind of neat. So you can, breathe in deeply, or you can exhale more deeply, or you can cough when you need to. But then there's also muscles in the rib cage that help expand our ribs and make our when we breathe in and out, help our rib cage expand and contract. So if someone has a spinal cord injury, sometimes those muscles that are in between the rib cage that's helping it move in and out, those muscles can be affected, which kind of impedes our breathing a bit, but people don't really notice those particular muscles. Now the diaphragm sits at the very bottom. It goes across the body. It sits at the very bottom of the lungs, and that diaphragm pulls down and pulls up, which helps bring air in and bring out. If the diaphragm is affected, people will notice that it's very, very difficult to breathe. And the diaphragm nerve comes from higher up in the spine, which is why people who have high spinal cord injuries will require ventilatory assistance to help that go, to help the diaphragm work, which is the phrenic nerve. But what people often don't realize is these muscles that help make the rib cage expand in and out, not up and down, but around our body, around the trunk of our body. A lot of times people don't realize that they might be having some slowness in those particular muscles. And so that probably is the biggest thing, is clearing out secretions if we have the flu or even a heavy cold, and making sure that our respiratory tract stays clear. The other thing, of course, is since we are on bowels, I'll go right back to it, but if you have the flu, that diarrhea can be, because it goes through your system so fast, you can get diarrhea, which then gets on your skin, which is very caustic. So because it's gone through your body so fast, it still has a lot of the digestive enzymes and acids mixed into it. As normally a stool goes through the bowel, those do their work, and then when the stool comes out, it's not quite so caustic. But because it goes through the system so very quickly, it can burn our skin, and so you have to be careful of those kind of things. So if you think you're having the flu, you can check with your healthcare professional and see if you're eligible to take some medications to help reduce the time that you have the flu. Many people with spinal cord injury might not be able to do that. So the best bet is to avoid getting the flu. And how we do that is probably the number one thing is by washing our hands, because when we touch things, we're able to pick up all kinds of flu germs that might be living, like on a shopping cart, or you might wheel through something and get some grime on your wheels, and next thing you know, you have those flu germs on your hands, and if you touch your mouth, your nose, your eyes, those flu germs now have entered your body. The other thing is to be sure and stay away from people who have illness. If they have the flu, ask them to stay home. Don't come visit you that day. If you have a person who's providing care for you, you might ask if you have a backup, if they can come until their flu episode is over. If you have a family member who has the flu and you're all in the same house together, there's really not a lot you can do about that. So you want to make sure that that person with the flu stays in their room, you stay in your room, so you're at least separated. And then, of course, make sure that glasses and dishes and toilets and bathrooms are very well cleaned after somebody either has a vomit episode or diarrhea, so that those don't get transmitted to you. And washing your hands and your caregivers washing their hands is very important. So let's move down here a little bit. When are colostomies necessary? Oh, that's a great question, because there are people who will elect to have a colostomy, which is when a surgeon goes in and takes part of your bowel, which is the large intestine, the big piece of bowel that connects right directly to the rectum. So you have your stomach that goes into the small intestine, and that's very, very long. And then you have this piece of large intestine that goes up one side of your abdomen across and down. So it's not nearly as long. And so what will happen is the surgeon will go in and take a piece of that bowel and cut the bowel in half, close off the end to the rectum, and then bring the bowel out through a surgical hole through the abdomen so that stool will come out. And I have had many patients that have said, I really do not like this bowel program. I am not going to do it. And they've gone for colostomies, which then you're wearing a bag and collecting your stool. And so that is an option that some people do. I think it's rather unfortunate, because after you have the colostomy, then that's like the extreme of bowel program corrections, if you will. So there is no place to go after you've had the colostomy. That's kind of the biggest thing that you can have done. But the reason why also you want to think about having a colostomy before you have one is, again, you're having surgery, which is very dangerous for people with spinal cord injury. So I have known people who have just insisted and have gone on their own and have had colostomies and actually have died. So I'm very hesitant about the colostomy. Now, if you have a problem and your doctor says, well, you have a tumor in your bowel and we have to take it out, you're going to have a colostomy. Well, yes, then you have to have one, or you're going to die from this other thing. So it's a very high-risk procedure for individuals, and it's really something you want to think about, because you can reverse them, but it's even more difficult after a spinal cord injury, because that part of the bowel that's been resected is now not going to, come back and start working again. So very, very complicated kind of thing. So when are colostomies absolutely necessary? And usually we save them as a last resort when people have so many complications from their bowels. And it's not necessarily from their bowel program, but it's more a complication from life itself. So, for instance, people who have irritable bowel syndrome, unfortunately, having a spinal cord injury does not exempt you from any other kind of diagnosis that may pop up, which is unfortunate, isn't it? It's like, okay, I've got enough. That should be enough, but no, people still get other kinds of colon problems, and so sometimes a colostomy is necessary. One of the problems after spinal cord injury, there is a colon problem called megacolon, and it is exactly as it sounds. Mega means really big, and your colon gets really big. It's from being having your colon over distended, so not performing your bowel program enough. Those people who want to wait the 3 days or longer or do a bowel program once a week, it's just not enough, because you've got stool, you've got gas, you've got things that collect in your bowel, and they need to keep moving out. And so people will sometimes neglect that, and then they have problems and develop this megacolon, where their colon becomes so over distended and it can't shrink back down to its normal size anymore, and then stool just will not move through it. It just won't go at all. And so it's a huge problem, and people who do not have spinal cord injury can get megacolon, but it really comes more often with spinal cord injury because of the problems with bowel program. Now, it doesn't mean that you didn't. It could mean that you've ignored your bowel program. It could also mean you've done everything exactly right, and still, because of your neurological injury, your bowel program just is not going to work correctly, and then you end up with megacolon, not for any reason of anything that you've done, but unfortunately it is just an unfortunate consequence sometimes of spinal cord injury, and so we have to be very careful of that, and we really don't want that to happen. So we have another person who has colitis, so that's inflammation of the bowel. Now, that's not necessarily megacolon, that's just an inflammation of the bowel. And so he's been having some trouble trying to get his bowels to move through, and he's doing his bowel program but not getting any results. He repeats the bowel program the next day, not getting any results, and then he has an enema, and then he has a very large BM. So things are just not moving through, and that bloating that's going on. So here again, when things aren't moving through very well, I wonder if you've tried some of that psyllium or any of those bulk fibers to try to get the stool to move through. Another thing also is drinking plenty of fluids. If your cardiac status is healthy and you can increase your fluids, and again, don't just say, okay, I'm going to increase my fluids, so I'm going to go out and have, a jug of water from here on out. Just add a cup of water, every day, and after a few days, you can add a second cup of water so that you can build up to your 8 ounces of water, 24 ounces of water a day, depending on where you start and where you need to go. So try to build up your fluid. That helps immensely. And again, looking at that bowel program, being really hypercritical of yourself. Are you getting the suppository next to the wall? Are you really dilating that internal sphincter? Adding fiber, adding fluids, and that should really help move things along. Here we have another question about smoking. And this person has smoked, but he's around a lot of smokers. And so that's a problem if you have any kind of paralysis in your respiratory system. That's going to, is going to collect in your lungs and stay there if you can't get it out. But for all of us, breathing secondhand smoke is very dangerous. So, we really want to avoid being around people who are smoking. If you're not able to talk to them, you don't want to give up your friends, or it's family members, or it's your caretaker. Ask them if they'll smoke outside the house. Now, a lot of those fumes stay on people's clothes, so if you're not a smoker and you encounter someone who is a heavy smoker, those fumes are still there. I know I'm a work in a college, and I get a lot of papers from students. And so I'll be going through a stack of papers and grading it, and this is papers that maybe have been turned in the day before or whatnot. And so I get the stack of papers out, and there's this little faint smell. And as you go through the papers, all of a sudden you come to one, and you can tell the student is a smoker because the smell of smoke on this paper, even days later, is so very, very strong. And so as long as you're getting that scent of those cigarettes, you're still breathing in that's nicotine. And so you really want to try to eliminate smoking. It's a very hard thing to give up smoking. It's an addictive drug, nicotine. Once you become used to it, it's very, very difficult to give up. But the good news is that there are products out there that can help you get through this process. There are some excellent prescription drugs that can help you get up the process. But like all addictions, the person who smokes has to be the one to want to give it up. So that's a challenge for you. You want to avoid being around people who are smoking. If you can have a fan, a little small fan next to you that's blowing the smoke away from you, it's even a help. It's not going to be that great of a help, but it would be somewhat of a help to kind of keep that nicotine out of your lungs. Here's a question. If you have DigStim and you have a very small result, can you repeat the process until you get a good result? Why, yes, you can. Normally we say to do the DigStim twice, about 5 to 7 minutes in between the events, the DigStim events. And so we usually say twice. If you need to do it the third time, that's fine. Sometimes when you do the digital stimulation, you will find that you will be removing some stool when you do that. And that's okay because the stool has gotten that close to exiting your body, and so that would be really great if you could, if you just need to help bring it out a little bit, and then that will help the softer stool up above will automatically come out by itself. So can you repeat it? Yes, you can. If you're having to do digital stim more than twice, or 3 times is probably okay, and 4 times is kind of out there way on the edge. But if you're finding that you're having to do digital stim numerous times, then you're going to want to change something in your bowel program to help that stool become more easily to be expelled. So if it's a very dry, constipated stool, then you can add stool softeners to moisten it. Of course, you can take the fiber or the psyllium, add to your diet. Fluid will help. Another drug that's out there that is a prescription drug is a drug that just coats the outside of the stool, making it easier for it to slip out. So some people take that and they think, oh, I'm taking a stool softener, but there's drugs that just coat the outside of the stool. Now this is kind of something that really is bothering me, but I'm going to bring it up here because it seems like the place to talk about it, is talking about bowel drugs. And it always shocks me because when you go to the drugstore, you have to ask for those drugs. They're not prescription, but stool softeners are these drugs that coat the bowel. Well, that one I think is prescription. Okay, but you go and you ask for stool softeners. You have to go up to the pharmacist and ask for them. You can't buy them over, you can't go up to the counter and just pick up one and go. And I always think, what is so valuable about stool softeners that they keep them under lock and key? They keep them behind the counter. It must be a hot commodity drug. That's the only thing I can think of. Anyway, just a little, I don't know, bowel humor, I guess. But I always think, why are these stool softeners always so locked up? Just always cracks me up. Okay. So ischemic colitis is the question that the person is adding on there about they have so colitis. So it's ischemic, which means that Ischemia means that blood is not getting to that particular area, and so it's that part of the bowel is not getting the oxygen and blood resources that it needs to work. So that is something that you are really going to want to talk to your physician about, because the colitis means that there's some swelling, and it's swollen because it's not getting the bowel's not getting the internal body nutrition that it needs to keep it working. So you'll want to talk with your healthcare professional about what kinds of things you can do to help your body deal with that challenge, because that is going to be a very unique process to you there. So here's another question. After bowel movement, this person has had a large clear gel discharge that has a bad odor. And so not seeing it or knowing exactly what that is, sometimes that clear gel discharge can be some lubricant that's been left over in your bowel that's maybe been and has picked up bad odor, or sometimes it's a little bit of stool that has gone through. Being clear, the bowel product is not usually clear. Now if it's liquid brown stool, it's some loose stool that's just kind of hasn't been metabolized by your body at the end of the bowel program. But usually if it's this amount of clear gel discharge, it's usually lubricant that's coming out later after the bowel program. So it's done its job and it's picked up the scent of the stool, and that's why that a particular problem has existed. So if you think it's lubricant gel, it probably is no problem. If it's something else coming from your bowel, I can't really imagine what it would be, because stool, because of the bacteria that interacts with it as it goes through there, it usually is some shade of brown that is emitted. So that probably is lubricant, I am thinking. You might want to save a little sample of it and show it to your healthcare professional, just to be on the safe side, since I can't see it here. And then we have our person with the ischemia. They've had some polyps, and again, it's unfortunate, but just because we have a spinal cord injury, the polyps are little pouches that descend into the bowel, and when we have our colonoscopy, the doctor removes those for us. Sometimes they bleed if they get irritated. This person with the ischemic colitis has had polyps, and so if those have been removed or if they have opened, perhaps they have bled somewhat, and that's caused that bit of ischemia that's going in there. So if the ischemia is just a little bit here and there in the bowel, then you're not going to really have too much to worry about. You just want to make sure that the polyps have been checked for cancer. Many polyps are benign, which means they are just little growths that just grew there, and the doctor removes them in the colonoscopy. But sometimes those polyps can be cancerous, so you do need to have those checked by the doctor. But I see we are at the top of the hour. And I know people always think, really, you can talk an hour on bowel programs? Well, I could go on and on, but unfortunately our time is up. So with that, I would like to thank everybody for coming to the webinar today. And be sure and listen to, be sure and write in your questions if you have any to the Nurse Linda blog. And we'd be happy to take questions at any time during the week. I answer them as quickly as I can get to them. So if you have any questions, feel free to write in. And if you have any questions about your bowel programs or anything else that is filtering on your mind, I did have a very interesting question from one of the readers this last week, which was about a drug that you see advertised on TV that works within the nervous system to help stimulate the bowel to work. And so I did write to the company and asked them, in fact, I called them and asked them if it had been tested for individuals with spinal cord injury, and in fact it has not. It's developed for people who take opioids for pain, narcotics for pain, and so that slows the bowel. The unfortunate part of this new drug is that it does cross the blood-brain barrier because opioids do, and so it goes in and counteracts that effect in the blood-brain barrier. So not really recommended for individuals with spinal cord injury. But it was a good thinking idea, and I thought, wow, I wish I would have thought of this. So, why not? And so we found out why not, and it was an important piece of information. But if you do come up with any great ideas, let me know, and I'll investigate them for you. So, Julie, do you have anything else that you would like to?
Right, I just want to remind everybody that you are in our community answering questions on our online community every Wednesday from 8 to 9, and I know you're there a lot more than that. So if we didn't get to any of the questions on this hour chat, please leave your question for Nurse Linda on our community. Join our community, and also if there's so many people in our community that definitely make some friends there as well. And we will be back next month with a live chat with Nurse Linda, and I'm anxious to hear what we're going to talk about then.
Okay.
So I want to thank everybody for joining us today, and have a good rest of your day.
Thanks, everyone. Bye.